Hello, today we'll present to you our ongoing research on the detection and classification of levels of consciousness during deep sedation using a parietal EEG-fNIRS. My name is Catalina Zaini. I'm an undergraduate student at Universidad Católica de Chile, and Gabriela and Carlos are two PhD students of the same institution. How do we measure levels of consciousness and loss of consciousness during anesthesia? One common way to do it is using the electrical activity measured by electroencephalography or EEG. And here we have the common example of propofol, which is the most used anesthetic, where in propofol we can see a significant increase in the alpha wave compared to wakefulness when there is loss of consciousness. This is used in monitoring systems like the bispectral index, where if the person, the anesthetized person, is kept in a bispectral index of 50, it means that this person is in general anesthesia. And this uses this appearance of the alpha wave as a measurement to say this. However, this has limitations. For example, the bispectral index uses only a frontal EEG band, which ignores the relevance of other brain areas that are related to consciousness, especially the parietal cortex. It is also not an indicator for some anesthetics. Here we have the example of ketamine, where there is not an increase in the alpha wave, but on the contrary, there's a significant decrease on the alpha wave when there is loss of consciousness. So the bispectral index is not capable of monitoring the levels of consciousness with this kind of anesthetic. It is also a private algorithm. And the problems of all this is that there's a not very well accuracy for the levels of consciousness, and this can have the consequence of an under or overdose of anesthetics. This is problematic because an underdose of anesthetics can result in intraoperative awareness, which means when the person wakes up during their surgery with anesthesia without the clinicians noticing, and this can be a very traumatic experience. And with an overdose, there can be neuronal damage because even though anesthetics are deemed safe for human use, they're still neurotoxic. And this is especially problematic for vulnerable population, such as people that already have neural damage or the elderly. So with this, we can think of alternative monitoring systems and enhanced monitoring systems. And for example, we can think of other ways of measuring loss of consciousness or levels of consciousness. And one example of that is measuring the hemodynamic activity. And this can be measured with different kinds of measurement systems, but one of them is the functional near-infrared spectroscopy, or EFNIRS, that it's an optical system, but that measures hemodynamic activity in the brain. And here again, each anesthetic has its own pattern of activity when there is loss of consciousness, and propofol has a specific one which is different to ketamine, which is different to other ones, but it can be used also as a biomarker of loss of consciousness. And moreover, we can mix up for example, EEG and fNIRS to create a hybrid system that is known to have better accuracy because it combines the pros of using electrical activity and hemodynamic activity, and then you have a more complete phenomenological context of what's going on in the brain. So with this, our objective is to determine the electrical and hemodynamic brain biomarkers associated with the levels of consciousness between wakefulness and deep sedation using a parietal EEG-fNIRS and machine learning. Our subjects will be relatively healthy patients and patients that are undergoing an endoscopy procedure because this is also a relatively stable procedure and a safe one. Patients will also be between 18 and 30 years of age, and we will have an N of 25. And all of these patients will have a gradual infusion of propofol and only propofol until loss of consciousness. They will be with eyes closed, lying on the side. The external disturbances will be only that of the typical clinical room, which we cannot control. And we will measure throughout the whole endoscopy procedure. And so we have four main conditions. One would be no sedation, where we would do a baseline screening. Another one, sedation induction, which has various steps and interests as most, a sedation maintenance, and then a sedation withdrawal. So in the induction of anesthesia, we will use a qualitative scale of measurement of levels of consciousness, which is what is mostly used in endoscopy procedures. And here we will separate this in different levels of consciousness we wish to classify using this modified Ramsay scale, which differs the levels of consciousness by the different behaviors the person have, by different responses the person have. So a first response or loss of response would be a loss of verbal command response. Another one would be the loss of response to pain, and another one, the final one, would be a loss of response to electric pain. And then the patient, using other physiological measurements, also obviously is assumed to be or to have lost consciousness. So this is what we will use for our classification. We will use to measure a multimodal EEG-fNIRS system, which is shown here in the image in the parietal zone. And our features for the EEG will be the power bands, delta, theta, alpha, beta, and gamma. And for the fNIRS, the concentrations of oxygenated and deoxygenated hemoglobin. And for each window, we want to obtain the mean, peak, and slope of our regions of interest. The classification, we will at first at least use a support vector machine classifier with radial base, which will be experimented in 3 models, EEG, fNIRS, and EEG plus fNIRS combined. And as I said before, the classifier predictions will be compared to this modified Ramsay scale levels. And with this, we expect to develop a machine learning algorithm that is capable of decoding sedation levels of consciousness in patients with above chance accuracy. And with this, to be able to give complementary information and enhance classification accuracy for better anesthesia induction and maintenance, and not have all the other problems of the under or overdose of anesthesia.